Good evening all. On behalf of Abbott Vascular, I am welcoming all for this webinar. It's my pleasure to introduce Dr. D.P. Sinha sir. He's our mentor and expert panelist for this webinar. Dr. D.P. Sinha sir is a retired professor from SSKM Hospital and he is senior most intervention cardiologist from Kolkata. Sir is secretary of Society of Cardiac Intervention SCI body. Sir is currently associated with ILS Damdam Hospital as a senior most intervention cardiologist. So over to you, Dr. Rajiv Bhanja sir, for the next case and the session.
Okay, thank you, Rahul. Actually, sir, thank you for your presence in this small meeting. So I will just present my simple case. Just I am trying to present in simpler ways.
So your screen is not yet shared.
Yeah.
Please click on share screen at the bottom. Hello, Dr. Rajiv sir. Hello.
और कनेक्ट थोड़ी से रुक जाओ, हो नहीं पा रहा ना, मैं कर रहा हूँ, just 1 minute.
Okay. So just click on share screen option. Milan sir, are you ready with your case?
I think that since Dr. Rajiv has some issues which is, let's say, uploading his video, if Dr. Milan Satpathy is ready.
Sir, actually, my laptop is corrupted. 2 seconds चाहिए sir.
Okay, okay. Okay, Rajiv, have your time. Take your time, take your time.
Yes, sir. Yes. Rahul,
Hello.
hello.
Yes. Yeah.
Am I audible?
Yes, sir.
So I just share my screen. Na?
Yeah.
Okay.
So click on share screen option.
So,
So is it working?
yeah. Just a second. Is it visible now?
Yeah. Okay, Milan.
Yes, sir.
Yeah. Go ahead.
Thank you, sir, for giving me the opportunity to share something. So, myself, Dr. Milan Kumar Satpathy from Apollo Hospital, Bilaspur. So now I'm going to present a case. A patient comes to us with a chief complaint of chest pain for about 2 weeks. It has intermittent in nature and it is increased. It is typical anginal pain, which is increased during exertion. There is a history of hypertension for which patient has taken antihypertensive for 5 to 6 years. There is no history of diabetes or smoking or alcohol. So on the time of admission, this is the ECG. The ECG just showing some co-test in V1 and some T inversion in AVL. Otherwise, patient don't have any specific STT changes other leads. But due to typical anginal nature of the pain, tropi was sent. It was quite high, 2,679, and in 2D it was there is a WMA in LED territory with trace MR without any effusion or clot, and ISIV is intact with ejection fraction of 35% to 40%. So This is the coronary angiogram of that patient. It was showing a critical LAD lesion in the proximal segment. It was around 99% in the proximal LAD. In areocaudal view, it is typically seen in LAD, but another is OM, osteoproximal lesion, is there 80 to 90%. So because of the nature of the disease, the culprit vessel was LAD, and LAD stenting was done on the month of March. But it was after that LAD stenting, patient is undergone contrast-induced nephropathy. So the second stage plastic was done in April for this OM. So I'm going to present this plastic over from L6 to OM. Just a second. Sir, so because of say there is a osteoproximal segment lesion in OM1, and it was more than 2.5 millimeter vessel. So I am thinking of about and there is no plaquing over the L6 segment or the proximal L6 segment. So I'm just thinking for stenting only the OM lesion from L6 to OM. So for that, I have done pre-dilatation with 2.0 into 15 millimeter balloon. And after that, I'm gone through that 2.75 into 15 millimeter biomime stent. But unfortunately, during the during that procedure, the stent is pulled towards proximal segment. So there is missing of the distal segment, some 2 to 3 millimeter distal segment just missing, for which we have taken another stent of 2.75 into 13 millimeter in the distal part of the distal part of the proximal stent. So after that, we have balloon post dilated with 2.75 into 10 millimeter balloon. But after taking a shot, there is a significant narrowing of L6 mid part where the OM is just origin. So at the point of origin, it was just around 80 to 90% lesion in L6 segment. But previously it was not. There is no plaque nearby that OM segment, OM branch. So for which we are thinking for another stent, but due to some dilatation of this mid part of L6, we just go for a kissing balloon, kissing segment. A kissing balloon was done with 2.75 millimeter in OM and 2.5 millimeter in L6 segment at pressure of 10 to 12 millimeter of mercury. After that, the final result was this. So this is the final result, but it was not at that acceptable limit. So just because the patient is having contrast-induced nephropathy and already there is stenting of LAD and 2 stents in OM, we just leave this procedure with this kissing segment, kissing balloon inflation.
Yeah. Yeah. Dr. Milan, your case is finished here.
Sorry, sir.
Your case is complete here. You have done anything more?
Yes, sir.
You have done anything more, or just completed? Let the patient go at this point of time.
Excuse me, sir. Hello.
Yeah. Have you done anything more? Or
No, sir. After kissing, I just leave that patient, sir. Yes, sir.
Do you have any follow-up data?
Sir, patient after that, patient is having 2 follow-up. Now there is no chest pain, no angina, nothing, sir.
So there are several learning points in this particular patient. In this, you go back and look at the ECG, past presentation ECG. That ECG is what we call an ST-MI mimetic. You know,
Yes,
there's a widened QRS in the B1, B2, B3, with some ST segment upward coving. That is,
Yes, sir.
some of the authorities will call it an ST segment mimetic and will treat it as an STEMI with immediate angioplasty. This anterior wall, LAD anterior wall, was also thrombotic, and anyway, you did it well to do at that time. And contrast induced nephropathy is unfortunately a real life phenomenon. We cannot escape that. The second point is this, that when you do an branch LCX to OM, there are other several techniques when you can use that particular technique to use the branch stances only deployment. You either put in a balloon in the main vessel and pull your stent up, and then fixing against the stent, you can deploy the stent properly. In which case, you may not have gone through all the problem of, might not have to go through all the problem of doing an LCX. But anyway, having done that, and there is a fairly common event which happens that the stent slips up because the heart movement is there. One way to use this movement-induced artifact of stent migration is either you use a long sheath to stabilize your guide wire, in which case, guide catheter, in which case the movement is cardiac movement-induced stent migration is quite less. Or what happens is that you can use a guideliner to fix the stent at the point of time. But I think in this particular case, what you did was right. You did a post balloon dilatation of the stent and a kissing. That's okay. That is a perfectly acceptable result and perfectly acceptable outcome of the patient. And one thing about contrast nephropathy. Sorry. Are you there, Milan?
Yes, sir. Yes, sir.
One thing about contrast nephropathy is this, that everybody should try and practice minimal contrast use during the angioplasty, in which case you can be able to reduce the contrast load. And of course, giving preoperative IV fluid and continuing it post-procedure IV fluid helps to a large extent. But overall, your outcome was quite satisfactory. Though I would have much preferred if you had shown us the movies of the case. You just show us some screen grabs, but the movies would have been nice, looked nice. Thank you. Thank you, Milan.
Sunil is there? Hello?
Hi,
Sunil?
Yes. Can you hear me?
Yes, just now.
Yeah.
Sunil, any question?
So I just, I mean, that sign actually that sir is talking about, that is called De-Winter sign. De-Winter sign. That tells you that it is. Yeah.
That is a
That tells you that it's actually proximal LAD.
considered as a STEMI equivalent.
Right. So I just wanted to know, Dr. Milan, I mean, you just took, angio you just took one view. You are doing just in one view, or you took, because I'm not able to see, more than this one view. You did angioplasty in RA caudal only, no? Epicaudal or RA caudal. Can you hear me, Dr. Milan?
Hello. Yes, sir. Yes, sir.
Milan.
Yeah, I was just asking that, have you took, multiple views, I mean, at least two views to see the ostium of the OM, and you just need to see, I mean, you are placing the stent at the ostium, or what was your plan? Just to cover the ostium of OM, or you want to, at the time, you want to cover just the proximal part of L6 also before OM? I think you are muted.
Hello, sir.
Okay, yes.
Sir, my plan was, sir, to stand from L6 to OM, sir.
Your plan was initially to stand from L6 to OM.
Okay. Sir, L6 to OM.
Okay. And so it was like your provisional stenting.
Hello.
It was just like a provisional stenting.
Yes, sir. Provisional stenting
You
because
just wanted to keep
there
it
is no
simple and
breaking
provisional stenting.
across the OM in L6, sir.
All right. So what other strategy you can actually go after this? When it happened, like there is a pinching of large LCX,
Yes, sir.
and what other things would have thought about it at that time if there is no issues of contrast nephropathy?
Yes, sir.
So if there would have been pinching and TME2 flow in the distal part of the LCX, well, I mean, what would be the other strategy? I mean, to bail out.
Sir, actually, I have to put
Because I think it was just 2.5 millimeter stent, and just
hello.
because it has covered around,
The voice is not audible, sir.
Dr. Rajiv, can you try switching
7
your
millimeter
video
of
Actually, sir, because
let's
of
suppose,
network, probably
there have been
I am just
TME2 flow of distal
getting
part of
ready.
LCX even after this kissing balloon, then what would have because
Hello.
what would be your strategy if there would be LCX even after balloon dilatation? In this case where the proximal the stent which has covered the LCX is just 6 to 7 mm, and there is also some disease proximal to the stent also in the LCX
किसी का
disease.
voice actually
Yes, sir.
ढंग से पूरा आज का पता नहीं नेटवर्क में एक बार बिल्कुल सुनाई नहीं दे रहा.
Hello.
Sir, can you hear me?
Hello.
Hello.
So, Sunil sir, your voice is a bit on lower side.
Am I audible or not?
Sir, you are audible, but
Okay.
voice is not
Voice
coming
breaking.
properly.
Okay, I'm not clear.
Can you try?
Audible?
उन्हें ऑडिबल मतलब ठीक से सुनाई नहीं दे रहा किसी का वॉइस. मैं भी खाली सुन रहा बोल थोड़ा सा डिफिकल्टीज हो रहा है नेटवर्क में.
So can we go to next case?
Yeah. I think Rajiv has.
Okay, I will present my case.
Recording in progress.
Rajiv sir, you have logged in from 2 devices, I think.
Yes, ऐसा क्या? Okay, I am just have it.
Sina sir, hello.
Yes, I'm here.
Sir, there is a question in chat box. from Dr. Sunil Gunyal sir. What will be the next strategy if final LCX is TIMI2 flow?
That's a very important question. That if we get a TIMI2 flow, but apparently and stenosis less than 70%, then it's a very dicey situation, which basically means that there is some microemboli has happened to the LCX due to let's say atherothrombotic plaque rupture and dissipation. In that case, I would like to put the patient on a GP2B and hope for the best. Okay, Rajiv.
Am I audible? Am I audible? My screen is visible to all?
Your slides are visible, but your voice is very weak.
Today I have it.
So can you share screen from here on this from this laptop, or I think yeah, it's now open. So just make it full screen.
Is it visible? Is it visible to all?
Yes, yes. Now we can see the
It is
video.
visible.
This is a simple case. This patient basically a 58 years male patient. He had interval MI for some duration. He presented with effort angina class 3, and this is a coronary angiograph of left system. Right system was normal, very short. So I thought I did angio, and this is the angio of in a PA cranial view. You can see this is the angio of LAD. Then I advised for angioplasty to LAD. I thought it will take some minutes and I will cross the OR and I can do it. But patient refused and went home. After 2 to 3 days, patient presented to me with again class 3 angina of a patient sweating, angina on his nose. So I thought I will and ask him to do angioplasty, and it will probably take one stent and I will do. So when then you can see this is all the view of the LAD. From this, what is your impression, Sunil and Sir Sinha sir? What is your impression about this from the angiogram?
Okay, seems to be some amount of viable myocardium in the anteroapical area, and you might be right. And there's some sort of thrombus holding up in the LAD. Also, there's a thrombus staining in the LAD. So we have to be a bit careful about what you are doing. Node flow is going to give you a big headache.
What is your choice of guiding and OR about for this patient?
Look, from the picture that I am seeing, I am not very much confident there's not very much confident that there's no calcium. But anyway, I would go start with an workhouse wear. Generally, in such a situation, start with your workhouse wear, whatever wear you use, and then go along to the demand of the situation.
And Sunil, what is your impression? Sunil? Sir, actually, I did simple, basically, first BMW universal wire I took, actually, whatever available in our lab at the time. And I try to
Yeah,
cross.
I just want to more views like.
Sunil, you are not audible clearly.
I am able to cross the lesion, not much but difficulty, but with some difficulty I am able to manage to cross the lesion. But though I cross the lesion, but I am not able to predilate the lesion with minimum diameter at up to even 1 millimeter balloon also. So it was difficult for me. I took two. I thought I would cross with two balloon, but it was not possible. Then 1.5, 1.2, 1, all balloon I have tried, but it was not possible for me to cross. Then at last I thought it is not possible for me. So even finally if you will see, all balloons I have tried, multiple balloons, but it was not able to cross the main lesions. Wire was very distally. So at the last moment, I thought it is not possible to me, and I gave up. Then I took a fine cross. Last minute, I took fine cross, but it was very difficult again because already wire was out. I didn't know in which plane wire is going, but somehow I am able to manage to. With this, I am able to manage to put my fine cross at very distally. Again, you can see the view. This is I am in proper position. Then I thought I will do my job. I will cross with the balloon at least 1.2 or 1.5. But again, it was too tough for me. Somehow again I have to take 1 millimeter balloon to 1.2. Then this is the 2 millimeter balloon to 20 millimeter balloon, and I will. Though in lesion it was saying that it was not calcified, but it was too tough to do all this procedure. Then after that, I thought I will put the stent and I'll come out because the oil was very distally. But again, it was not possible for me. I have taken an NC balloon 2.520. Still also not possible. Even after, if sir, what is your impression at this juncture? Sinha sir, what is your?
Really, as I said, that from this imaging that I am seeing, it is difficult to appreciate any calcium. But most of the time, such difficulties happen if there is a calcium spicule, calcium spar protruding inside the arterial lumen, which basically tells you that your wire might cross, even you might cross with a balloon with a difficulty, but it will usually tends to catch hold of the stent. And one more thing, what is the guide catheter that you are using?
I used to exploit Judkins.
So in such a situation, since you have taken out the wire once, I would have suggested that you take a other backup guide catheter like EV or XV, which gives you.
Maybe, yes, sir. Yes. Sunil, what is your?
I think, you can use also guide extension.
यार वॉइस ब्रेक हो रहा है.
Even after this also, it is not possible to put the stent. I have to make body wire. Then if you see, it was
your problem is the stent is not going. No?
stent is not.
What was your problem? The stent is not going.
Initially, the balloon was not crossing. Most important is then even after properly dilatation with 2.5 NC balloon also stent was not going. Then I did body wire with putting another wire. After that also it was very difficult. I am able to cross the lesion to put the stents. But the lesion is not looking that much calcified, only simple 20 millimeter near about 90% critical disease. And just like CTOs, if you'll cross the wire after that also it is not possible to cross with the balloons. I think everyone has faced this type of cases in CTOs, but it seems not to be a CTOs. That's my reason that what is your impression when you will start this case? So in body wire, I am able to cross this stand. And this is the engine. Then after that, with NC balloon, I have again post dilated the stands properly. And this is the final result. And you will see what is the LED size and see.
Yeah, Dr. Hanja, yeah, you did good, but as I said, that since you have, I am not sure whether you had any imaging facility available in the lab. You have any imaging in the lab?
No, imaging, we didn't have imaging, sir.
You don't have it. No, that could have told you what the real problem was. And I believe the real problem was some sort of calcium spar which was holding you everything every time back. And with your lack of backup support of guide catheter, that which is exemplified, but when you take a body wear, your support improved and you could push the stem. That is the what happened actually.
But that is definitely probably I have not taken the guiding. But sir, even after the wire was crossed very nicely, it was not that much difficulty. But even the smallest size balloon also not able to cross. Even CTOs.
Most likely it is a calcium spar which is holding.
Exactly.
Back.
I think this is the case. We can do at least imaging will help us.
Imaging would have told you what the actual event that is happening. Okay.
So this seems to be a very simple lesion that one can do.
No angioplasty is ever simple. If you think an angioplasty is simple, it will take you several hours to do a very what you think is a simple case. Okay, that is a nice case. There's a nice case, large LED, well recanalized.
LED, exactly. It was very nice. LED is very large actually.
Large LED, has to recanalized.
I think this angina may reduce with this type of result. Because
the angina should definitely go. Okay, that's a nice result.
Thank you, sir. Thank you. Sunil, are you audible?
Sir, I think Sunil sir is not there. Can we move on to next case? Dr. Gaurav Tripathi sir joined just now.
Okay. Thank you, sir. Thank you, Milan. Thank you, Gaurav.
So, Gaurav sir, can you share your screen for your presentation? Hello. So your voice is not coming. Hello. Am I audible? Hello. Hello.
Yes, you are audible. Yes, you
Yeah.
are audible.
Sir, Gaurav sir, can you share your screen? Hello. Sir is logging out and log in once again. He's facing some network glitch.
Okay.
Just wait for 2 minutes. So we can see you. Your audio is not get connected. Not yet audible, sir. Audio is connecting. Sir is logging in again.
Rahul, Rahul, is there a problem?
Sir, Dr. Gaurav sir is rejoining. He is facing some network issues. He is just joining in 1 minute.
Actually, in Chhattisgarh, sir, due to heavy rain, now probably network is little difficult.
Gaurav sir, can you hear me?
Yeah, I can.
So sir, just click on share screen. Your voice is audible now.
Yeah. Are you able to see my screen now?
It's coming. It's coming.
Some NGO shots you can see?
Not yet. Not yet.
Yeah, not yet. Angiogram, I'm showing you some angiograms.
No, no,
No.
no.
Let
It
me show
started. It's showing. Yeah,
let me
it's
show me
coming
let
now.
me show you another case then. Okay.
It's
Now it is coming.
Let me show you this case then. If possible. Patience with me. This is tough evening for all of us.
So the videos are not running.
Just a sec. Just a sec.
Yes.
Now they must be running. No, no, not yet.
Not yet.
And now, yeah, now visible. Screen sharing is paused. Somebody's okay.
So videos are not coming.
Yeah, yeah. Returning, that's right.
Sir, am I audible? Hello.
Yeah, you are.
Sir, the videos are not running. Do you have any other case with the presentation?
I have a lot of many cases, but none of the videos are running actually.
Okay. The
Too
PPT
many
having
cases.
that slides.
Can you see the slides now?
I can see the slides, but the videos are not running.
Like videos are not
I
running.
can see the runs. You converted it to, I think, VLC player.
Now, yeah, I have shifted them. You cannot see it, but
No, no, the videos are not running.
and what about this DICOM waiver? Let me try this if possible. I'm trying Rahul, just a sec.
Okay, sir.
I know I'm a troublemaker today, but
Sure, sir. Hello.
yeah.
Sir, I think maybe due to some technical errors, the videos are not running.
Yeah. To that.
So Dr. Rajiv, sir, can we conclude the session then?
Yes, yes. I think we can conclude this session because Dr. Sinha was his time is very important. He's for last 2.5 years. He's from the
Yeah.
very beginning.
Yeah. So
Thank
this
you, Gaurav, also
actually,
that he is trying his
can
level
I brief
best.
my case if possible, sir? In a
Yes,
few
no
words.
problem. You can brief,
So,
no problem.
this was a patient presented with unstable angina 6 months back. We did an RCA PTCA that time and LAD PTCA with a calcification all around. We performed a scoring and cutting balloon at that time, but the stent was well placed but slightly under. And the LCX PTCA was tried along with cutting balloon and stent placement was tried, but that was not successful due to a calcium nodule at the bifurcation site. So this time we plan to have an IVL in this patient along with the OCT backup, OCT imaging facility definitely, and we did use a guide Zilla, and even with guide Zilla there was telescoping of the devices. So guide Zilla was deep inserted, and then we did an IVL in LCX after a cutting balloon. And IVL in the LCX was done with a guide Zilla extension, and later on a stent was placed across OM, and optimization of LED stent at the simultaneously with IVL was done. 4 pulses were given to LED and 4 pulses in LCX, and OCT finally revealed a good results. I'm really sorry that I couldn't be able to show my slide. That was a good case to show, and probably I'll try next time to not disappoint you guys. Thank you.
Okay.
Thank you, Gaurav. Thank
You.
you. You did simultaneously LED and LCX.
No, sir, LED standing was already done. That was optimized with IVL this time. But LCX standing was attempted in the first setting with cutting balloon, but that was sufficient. So I had a plan of doing an IVL in the LCX. At the same time, I'll optimize the stent of LED with the IVL. And OCT will document the proper expansion. So that is what we did this time. But due to nodule, there was difficulty delivering every device. Even OCT was telescoping into LED while delivering it. So I had to use GuideZilla for delivering all these devices.
No, after stenting also you did IBL to LED to optimize the stent.
Yes, sir. That was the second part of this thing. LED was stent optimized 6 months later.
6 months later.
Yes,
okay.
Sir. And that was I cannot show you right now, but OCT did reveal a good expansion in LED.
Only IBL or any balloon? No.
So in LED only IVL, sir. In LCX, rest of the cutting and a balloon was tried.
Okay.
Because post PTCA only IVL can optimize this thing.
And
all other thing already been tried. So.
And LED OCT also done?
LED was just after osteal, sir.
No, after IVL you did OCT to LED?
Yes, sir, I did OCT. That was well optimized, sir.
Okay, good.
And LCX extending because of nodule that was not delivering. Although cutting balloon was passing very smoothly, but rest of the device this time was to make it more difficult. So we have to use GuideZilla. Even we break up one OCT catheter because of the scooping thing.
Some centers even for optimization they are doing after in second sitting also some centers those who are doing this type of cases to optimize the stents. But initial stage even stent was not optimizing. Later some operators are doing like this. In some centers only doing, not in everywhere. I don't think everyone is doing. In some centers only to optimize the stents when
Yes, sir. Because at the first time I was not satisfied with the result. So when I had a chance to do LCS later on, I definitely took an advantage of having an IVL in both the arteries.
This makes
exactly.
sense, this makes sense because once a stent is delivered, if you have difficulty, there are only two ways you can optimize the stent. One is definitely IVL, or otherwise you can go for this high pressure balloon. This,
Yes, sir.
you can go, and that up to 30 or 40 atmosphere, you can crack the whatever calcium is there or hypocalcific nodules are there, you can crack them. They are the only two accepted methods of post-deployment of optimization. Otherwise, you have to do whatever you want to do before you deploy a stent.
Sir.
Thank you, Sinha sir, for your valuable time.
Thank you. Thank you, everybody. Okay.
Thank
Good
you,
night.
Milan.
Thank you,
Thank you,
sir.
Sunil,
Thank you, sir.
if
Sorry
you are there.
from my side, sir.
Okay, thank you.